Thank you for attending today's Stress, Trauma, and Resilience seminar. Today, we are fortunate to have Dr. Kristen Roye, who's a licensed clinical psychologist who received her doctorate of clinical psychology from California Lutheran University. During her time at Cal Lutheran, she specialized in treating intimate partner violence and found a passion for attachment theory. She continues to use attachment theory in treating clients, doing research, and in training staff at her current role as clinical director at Destinations for Teens. Welcome, Dr. Roye.
Thank you so much. I'm really excited to be here. I am just having some, oh, there we go. Now the PowerPoint's going. Yeah, very excited to be here. Going to talk to you all about DBT. We're going to do our best to make this a virtual platform. So typically I would have some activities. It's going to be a little bit modified because we're virtual. But if you have questions, please feel free to ask. We're going to have some time at the end too for Q&A. So if you want to hold them until the end, we can do it that way as well. But today I just wanted to go over some of the objectives that we're going to be talking about. To clarify, this is going to be an overview of dialectical behavior therapy, specifically applied to the population of adolescents and families. There is so much information about DBT. It can get really a little bit complicated and complex, so we're not going to go over specific interventions or skills, but again, more of a basic overview. And if you guys have more questions and want to go further into that, we can potentially set something up in the future, but just a brief overview. So we're going to go over the structure of DBT, what the stages look like, some therapeutic assumptions, and the populations that are best suited. I've got some great resources on here if you are looking to utilize DBT in practice. I've listed some manuals and books that are really great references. We're also going to look at the biosocial theory behind DBT and describe how we can use it with our clients and families. We're going to talk a little bit about a few validation strategies that we can use in clinical practice. I will go over some mindfulness strategies as well, and then we'll talk about appropriate treatment goals for understanding, these complex multi-diagnostic adolescent populations. So that's my idea of what our time here together will look like. And I'm trying to go through the slides, but they're a little bit slow on my end when I'm jumping to the slides. So I apologize if they're not moving through quick enough. I don't know if someone else can change them. Okay, so anyway, moving forward, I don't know if yes, okay. Someone else is getting control of my screen. Sorry guys for that, to help me with moving forward. Beautiful. Okay, next slide. So this is just some helpful resources. We have your typical DBT book with suicidal adolescents that's written by Miller, Rathis, and Linehan. We also have the DBT manual. And then there's another really great book by Swenson called DBT in Action, Acceptance, Change, and Dialectics. And they're beautiful. Okay, so next slide. So we're talking about DBT and dialectics, but what in the world is a dialectic anyway? I know that for whenever I use it with my clients, they're always saying things like, my adolescents like to call it diabolical butthole therapy. That's a fun one that they say, or dumb bummer therapy. They like to come up with all of these terms to use. But really, when we're talking about a dialectic, we're talking about finding validity in both the black and white. It's two sides of an argument and finding validity in both of them, right? And some really common dialectics that we see in our clinical practice is we could have an adolescent who's highly suicidal, but at the same time, they have a really strong will to live, right? Our clients, we need to meet them with accepting them for who they are and where they're at. And it's also our job as clinicians to push them towards change, right? For some clients, self-harm could be a form of self-preservation, right? For many of our clients, they really hate their parents and love them at the same time. So it's really this understanding that two things that are opposite can hold some truth. So our job as clinicians is to really help clients understand this. We're going to talk about the 5 DBT skills. There's 4 in regular DBT. Working with adolescents, we add an extra skill. But the first one I wanted to talk about is mindfulness. If we are not mindful and in the moment and able to understand what's going on, both with us as clinicians, in our bodies, in our minds, and if our clients are unable to be mindful and present and in the moment, we're really not going to get much work done. So at the basic level, the first skill we always want to provide psychoeducation on and educate our clients on is mindfulness, right? So this is just a way of being attentive, thoughtful, and intentional, okay? Being aware of what's going on in terms of feelings, in terms of bodily sensations. Am I experiencing a craving? Am I, emotionally dysregulated right now? We really want to take a lot of time to train our clients how to be mindful. And the idea about being mindful also is to not be judgmental of what's going on, right? If I'm having a self-harming thought, I can have that thought, accept it, and not judge myself for having that, right? It's literally a way of staying awake and controlling one's attention, right? So it's a repetitive act of directing and redirecting one's attention and staying in the moment. So on the next slide, I like to use this breathing exercise. I usually do it with an audience, but because today's a little funky and we're virtual, I'll just explain how I do it. This is a great grounding exercise for teaching basic mindfulness skills, especially with adolescents. So I would start this exercise out. I would give everyone 2 minutes, or if I'm in the room with a client, 2 minutes together to do this. Have them close their eyes if they feel comfortable. Usually if clients have had some traumatic event, they may not feel comfortable closing their eyes. So you would just tell them to pick a spot on the floor or the wall to look at to sort of maintain their attention. And on their in-breath, they're going to do a mantra. So on the in-breath, they think in their head, just this one, and on the out-breath, moment. So just this one moment. And we do that exercise for just 2 minutes, and then you ask them how they feel afterwards. I find that by using a mantra, clients who typically have ADHD or they just have racing thoughts, they've got too much on their mind, if we give them a mantra to say, it really helps keep them grounded. Because if we just have them sit in silence for 2 minutes, they're going to be crawling out of their skin. They're going to think that mindfulness is absolutely not helpful for them. So we really want to break this practice down and make it very simple. So that's just one exercise to use. Again, typically we would do this exercise, but so just some themes that I want you all to keep in mind too when we're talking about DBT. And I was victim of thinking this way too. When I first started hearing about DBT and practicing DBT, I thought this is it's a manualized, evidence-based type of treatment. And I fell into this idea that it's very rigid, it's not flexible, it's not for me, right? And then I started to really focus in and start to learn some of the strategies and the principles behind DBT. And it really is a flexible, fluid process. And at the same time, it provides some really core structure that our adolescents are so desperately needing, right? So that's me saying that. I just want you to know that this is a flexible set of techniques that you can use. The central dialectic that we want to really encourage our clients and ourselves, because we can, really use this reminder, is that we are accepting our clients and families for where they are while also wanting to change them. I got a question. Yes, slides are going to be available afterwards for you. We're really, our job is to follow the principles of DBT, right? We're not going to be sticklers about the rules, okay? So we're following principles and providing some structure without being so rigid. It is a flexible, personalized approach that we're going to use specific to our clients and their symptomology, right? And then really, as a DBT therapist, our job is to focus on incorporating new skills to give to our clients. And we're going to strengthen those skills in session and help them generalize to use outside of our office. So on the next slide, we're going to keep going on with our themes. So the first thing is that when we're working with clients, we really want to not use judgmental language. And this, in treatment centers, I still see this. It's very challenging, especially if you're working with mostly borderline personality disorder clients. It can be really easy to fall prey to the chaos that they create, the insecurity in ourselves as clinicians, and it can be really easy to use judgmental language. For instance, in treatment team, I hear, honestly, probably once a week from clinicians that I work with, oh, that client's being manipulative, right? Or you'll hear people talk about, oh, they're acting really borderline-y, right? Or if we've got old school clinicians on this video, you might hear, oh, this feels really Axis too. And while we need to use some humor and debrief and talk about things in such a way that we're not being traumatized by our clients, at the core, these are really judgmental messages that we're sending, and we're continuing to stigmatize these clients. So we want to be really mindful of the judgments that we're using. And when I'm talking about judgments, I'm not just talking about negative judgments either. We can also, we can consider something to be positive, but still put a judgment on it. I'll give you an example. I had a therapist who I was supervising, and her client was talking about education. And the therapist was saying, how great it is to be educated and how education opens your world and provides you with all these opportunities, and how important it is to be educated. And she thought she was being very positive and encouraging this client. While it was positive, it was still her own judgment, right? It's not up to us to tell our clients what to do, but really help them guide their own way. So we just want to be mindful of any judgmental language we're using. Another thing we want to, oh, sorry, can you go back to that really quick? We want to avoid using the word manipulation, right? If you look up what manipulation actually means, it suggests that an individual who's manipulative is very artful and skillful. I don't know about the clients that you guys work with, but mine are not artful and skillful, right? They could probably actually become more manipulative. But that just has a really negative connotation. So we're going to take that out of our vocabulary. And I would challenge you all to, instead of using the word manipulation, use the word, they're being very willful, right? Very passionate, very willful. Okay, sorry, I just saw. So then the other thing I wanted to say about the words that we use, we want to stop using the word but. And I'd like you to replace the word but with the word and. And I'll give you an example. I see this often, especially with parents of my clients. They'll come in and they'll say, yes, Carly got an A on her history test, and we're really proud of that, but she got a C in math, and now we're going to have to hire a tutor, and she's not going to get into the college she wants. And what that's done is that's just completely invalidated Carly, right? She worked really hard for that A in history, and mom, by her saying the word but, just totally disregarded that work and is creating more of an environment of invalidity for her. What mom could have said instead, and just listen to this one word change, it makes a world of difference, right? You got an A in history, we're so proud of you. And you got a C in math, we're gonna need to work on that, right? It leaves the person still feeling heard, still feeling validated. So those are my two challenges for you all. If you learn nothing else from this presentation, let's eliminate manipulation from our vocabulary, and let's change the word but to and, okay? Those have such a powerful, powerful impact. We want to stay, right, we want to try not to pathologize all of our borderline clients, right? Not all borderline clients are difficult. They're not challenging, right? Let's really be mindful of how we're talking about our clients. Let's be mindful of how our treatment teams are talking about clients, and let's try and start changing that language, right? The other thing when we're utilizing DBT is that we are on the same playing field. Oh, yes, I got a question. What is the word to use instead of manipulation? Willful. Okay, so clients are being willful. What was I saying? Oh, we're on the same playing field as a client, right? I think that sometimes people come into us, they look at us as the professionals and the experts. Yes, we are. And in DBT, we are there to be our clients' cheerleaders, right? Nobody knows more about or is more expert in somebody's life except for that person, right? So we're really trying to take away this authority figure when we're utilizing DBT, and we want to be on the same playing field as the client. Okay, what populations are best suited for DBT? You guys can read this, but just so you know, it started out, Marsha Linehan obviously created this for women with borderline personality disorder. Since then, the research has been extensive. It has expanded to other populations, adolescents being one of those populations. They respond so well to it. Chronically suicidal patients are responding well to DBT. Individuals who are more challenging to treat or come with multiple diagnoses, individuals who have had multiple hospitalizations, self-injuring clients, individuals struggling with bulimia and binge eating disorders, and also a new interesting group that we're seeing a lot of research exploding from is actually depression in the elderly. So, and then just on the next slide, you'll see what some of the research is actually showing about what DBT is capable of accomplishing with clients. Is that we're seeing that there is a reduction in suicidal behaviors, SIB, depression, hopelessness, anger, eating disorders, substance use, impulsiveness, and risky behaviors. And because this is a strengths-based approach to treating clients, we don't want to focus on just the negative symptomology, right? We want to focus on what are clients gaining from this? Well, they're becoming better adjusted, right? We're seeing improvement in their relationships. We're seeing an improvement in positive self-esteem. We're also seeing improvement in the length of stay in treatment. So we are seeing some real gains, better emotional stability, ability to just tolerate distress, right? We're really seeing some great improvements. Okay, and then on the next slide, okay, this is just some more on the research of DBT. There's DBT and DBT Lite. I just want to make a quick little note about this. Some programs will offer skills-based only groups, and then they'll claim that they're a DBT program. I just have to give this caveat. A true blue DBT program is 1 year long for adults, and the individuals have to commit to a year. For adolescents, it's 6 months. Okay, if you do not meet those two criteria, you cannot call yourself a true DBT program. The other thing that a true DBT program includes is it includes 1 individual therapy session per week with a DBT trained therapist. It also includes 1 DBT skills group per week where the client is getting psychoeducation. They also have access to their therapist outside of sessions for phone coaching, right? So these therapists, you don't have to be available 24/7. You can have some boundaries, but clients can call you out of the session if they're in a crisis. If they're feeling suicidal or they're wanting to engage in self-harm. The caveat is that they have to call you before they've engaged in some type of suicidal gesture or before they've engaged in some type of self-harm. And then in order to be a true DBT program, you also have to be engaged in DBT consultation with 3 or more people per week. And the reason I say that is because DBT is really sort of this catchphrase right now. A lot of programs do marketing and say, we're DBT, we do DBT. So I just like to educate people on what that really means. Now you can say that you are DBT informed, right? If your therapists are trained in DBT, if they use some skills interventions, that's okay. And the research actually shows that implementation of DBT skills does show very positive results over time working with clients. The thing is that when you incorporate the skills, you just have to do it in a consistent and reasonable manner. Sometimes what I've seen treatment centers do is they cherry pick. They'll say, oh, this client is struggling with anger. I'm going to give them some distress tolerance skills, and I'm going to do some mindfulness here. I'm going to do some emotion regulation here. That doesn't work. You just have to create your program like I said, consistently, and there's a certain order and a certain way that you need to introduce and teach the skills. But as long as you're doing that, research is showing really beneficial results for skills-only based groups. What I like to go over is what are DBT assumptions about our clients. I trust that you guys can read this on your own afterwards, but I'll just highlight some of the really beautiful, important ones that I really enjoy. People are doing the best they can. People want to improve. At the same time, people need to do better, try harder, and be more motivated to change. That's that dialectic, right? We can understand our clients are doing the best they can, and they can do better at the same time. Both things can be true. I love this one too. People may not have caused all of their own problems, and they have to solve them anyway. I think that one's really beautiful, especially for working with adolescents. There's a lot of blame game, right? And we can get really sucked in this, I've been traumatized, I've been victimized. Yes, you can. And what can we do to get you to where you want to be? There's a great metaphor. DBT is all about the metaphors, right? And I like to use this with my clients. So say you're walking along a beach boardwalk. I have them pick whatever pier they like. I'm from Ventura. I really like the Ventura Pier. I'm walking down the Ventura Pier, right? And there's a banana peel. I step on it and I slip and I fall over into the ocean, okay? I didn't put that banana peel there. I didn't see it. It wasn't my fault that I went over, but I'm there now. What do I do? Okay, well, I can sit there and complain about the banana peel, and I can be frustrated and not do anything, and I can sink, or I can use some skills, right? I know how to float, I know how to swim, I can swim to shore and get myself out of the water. So sometimes when you phrase it that way, clients can really get behind that, and that can be really motivating. Another thing that I think is really profound in the DBT assumptions is that teens and their families cannot fail in DBT. And this is really liberating for people. By the time people are sitting in our office, they have been invalidated so many times. Teachers have told them they're no good. Their parents have told them they're no good. Their self-esteem is, flatlined. They're feeling really bad. Now they're being told this is something you cannot fail at, right? The same can be said if we were treating a cancer patient. We wouldn't say that they're failing their treatments, right? We would simply rephrase that and say, well, maybe we haven't found the right treatment for your particular type of cancer. We still need to find what works for you. So the same can be said of DBT, right? The clients aren't failing it. Perhaps we just haven't figured out what best way to work with this client. That's really empowering for them to hear. So in the next slide, we have DBT assumptions about therapy. I think like I said, you guys can read these, but ones that I really want to point out, DBT therapists can fail, right? Our clients can't, but we can. But on the next bullet point, we're off the hook a little bit, right? DBT can fail even when therapists do not. I'm getting a question. Oh, hold on, Q&A window. Oh, how culturally inclusive is DBT? They have started to expand it to Native American cultures. Mostly though, the research is on America and European cultures. So that is still in the beginning stages of the research. They are finding though that it is becoming more and more applicable to a variety of groups. What I have found that's really culturally, what does work is the DBT skill of walking the middle path. And that's really just giving parents permission to parent and giving them guidelines and helping them work with their teens come to some type of compromise. That I have seen just anecdotally work across a variety of cultures. But the research, again, is mostly on European, mostly white cultures, to just be perfectly transparent. But they are working on that. Good question. Let's see. I think I skipped some slides. I just wanted to make note of this really quick. When we are diagnosing borderline personality disorder in teens, This diagnosis can be made prior to 18. There's a lot of misconception that you have to wait until the person's 18. That's not true. What I do want to say is just be mindful if you're diagnosing this. This, unfortunately, is a diagnosis that holds some weight. It's still heavily stigmatized. And if you read the DSM diagnostic criteria for borderline personality disorder, I would say probably 75 to 85% of your teenage population meets this criteria. There's emotion dysregulation, trouble with relationships, trouble with self-identity. This is sort of the nature of being a teenager, right? So we want to make sure that this is really a pervasive personality pattern rather than simply a developmental issue. So we really want to be careful with that. Sometimes I will put in a treatment plan that the individual is showing borderline personality traits, and we're utilizing DBT to focus on those specific traits that, you know, can help. But we are seeing a huge influx of BPD diagnoses in teens, especially when they're hospitalized. That seems to sort of be the golden standard that we're giving clients. So I just want us all to be really mindful when we're diagnosing. Not everyone is borderline, and let's really be mindful of providing that. And on the next slide, it shows that DBT has really, instead of focusing on the symptomatic presentation of borderline personality disorder. Oh, should I take that slide out? Maybe, I think it's, yeah, there we go. Thanks, guys. So sorry about the PowerPoint confusion. Anyway, DBT has reorganized borderline personality disorder. So we're not looking just so much at symptoms and problems, but we're looking at a pervasive pattern of dysregulation in 5 main areas for individuals. So individuals who struggle with borderline personality tend to be emotionally dysregulated, right? Their emotions are labile, they're all over the place. They really struggle to accurately identify what they're feeling and to respond appropriately, right? There's a lot of anger problems, there's a lot of outbursts. There's also interpersonal dysregulation, a lot of chaotic relationships. There's extensive fears of abandonment. Perhaps there's some paranoia. There's a lot of jumping from relationship to relationship, a lot of toxic relationships, domestic violence. You'll see teen dating violence, a lot of early sexual promiscuity to keep relationships. There's dysregulation in terms of self, right? There's identity confusion, a sense of emptiness. So we also have behavioral dysregulation, right? A lot of suicidal gestures, self-injurious behaviors, and then the cognitive dysregulation. So there's a lot of disassociation or impulsive behaviors that when individuals are activated, they really struggle to have a logical thinking component, right? I'm getting a question, how much does anxiety show up in a BPD client? I would say often. I've never seen an individual with borderline personality disorder without another co-occurring condition of either depression or anxiety is often co-occurring. Sometimes bipolar disorder also. And that's a really great question. That's why we have to be so careful in diagnosing these things. Is this really symptoms of anxiety? Is this symptoms of PTSD? Or is this truly borderline, right? Because there's a lot of overlap. Okay, so if we can move to the next slide. I am needing to move on quicker, guys, but there's just so much exciting information. Anyway, the main goal of DBT for our clients is we really want to help them create a life that's worth living, which is just so beautiful, and everyone can get behind that, right? So we want to ask our clients, what makes your life worth living? What is it that you want to do? What do you want to accomplish? And every single time we meet with that client, every time we teach a skill group, we want to make sure that we tie what we're teaching them into their goal worth living, okay? That way they can get behind, like, why do I have to do this mindfulness? Well, you said that you wanted to go to medical school, right? So in order to do that, we need to do X, Y, and Z. So people can get behind creating their own goals. Next slide. How do we do this? Ultimately, what we're going to do is we're going to create a space of validation for our clients instead of blame, right? We're going to block problematic behaviors or extinguish them, and we're going to reinforce the good ones. Next slide. This biosocial model and the window of tolerance, this is really a core piece of DBT work that we do. Individuals who have borderline personality disorder, they have a genetic predisposition to have a higher baseline, or a higher, their baseline for emotional activation is higher than the norm, right? So they are triggered easily. They are triggered, they have a high sensitivity, meaning that if they feel that they're going to get abandoned or there's some type of emotional dysregulation, they respond immediately, right? And they have a lower threshold for response. So they are going to be activated and triggered more frequently than most of the population. They're going to have a very high reactivity, okay? Meaning their reactions are going to be very extreme, and their cognition during that time is going to be impaired because they're so activated and so highly aroused. There's going to be a slower return to baseline, meaning they are going to be emotionally activated longer than the average person, right? So they're going to stay in that activated state, which means that the reaction time is longer. And it also means that they are more highly sensitive to the next emotional trigger, right? So if they're in that highly emotionally aroused state and they are triggered again, they're going to hit their threshold, and they're going to engage in target behaviors more often, right? If we go to the next slide. We already talked about that. We can go to the next one. Thank you. I wanted to talk a little bit more about an invalidating environment. And one thing I want to say, that when we are talking to our parents about this, an invalidating environment just happens. No one does it on purpose, right? We don't try to invalidate our children on purpose. It's just that this person, their needs aren't getting met in some way, right? An invalidating environment does not have to be bad. It does not have to be abusive. The individual simply doesn't fit into this mold or their family for whatever reason, right? So some characteristics, and some of these situations might feel really familiar to you, right? Parents might reject communication of private experiences, and instead they're met with inappropriate or extreme responses. I'll give you an example. Client comes to mom and says, "Mom, I'm feeling really depressed and sad." And mom says, "Well, how could you feel depressed and sad? You have everything, right? We just bought you a car, we live in a nice house, you're popular." Okay, so then the kid decides to not go to mom. They go to mom again, right? "Mom, I'm feeling really depressed and sad." It's just a phase. You don't really feel like that, right? We're telling our children how to feel, and we're telling them, we're invalidating how they actually are feeling. So then the kid feels like they need to up the ante. "Well, I am depressed, I'm going to attempt suicide now." Then mom responds in the opposite way, right? Mom is responsive, receptive. "Oh my goodness, how did we not see this? We care about you, we love you." They're at the hospital's bedside, right? So we have inadvertently not reinforced the positive behavior of our child coming to us, but we've reinforced that hospitalization type behavior, right? So we've reinforced a bad behavior and we've created an invalidating environment. Not on purpose, right? But it did happen. So just there's many ways to create an invalidating environment. What you want to do is ask your clients what messages they're receiving and how are they feeling invalidated. And we can go to the next slide. We already talked about the DBT structure, right? So I don't need to go over this one. We'll go to the next one just because I have so much information to give you guys and really want to get as much as we can. Again, the function of treatment, we want to enhance our clients' capabilities, improve their motivation, right? We're creating a structured environment. Also, we want to enhance our abilities as a therapist. That's why we do the weekly consultation. So next slide. There are treatment stages to DBT, right? In order to be a fully true DBT program, the one thing is that patients have to volunteer for it, okay? They are fully informed of what DBT entails before, and they agree to certain conditions, right? One of the conditions being that they cannot engage in any type of suicidal behavior while they're in DBT. If this does happen more than one time, they will be asked to leave the DBT program and come back when they're more stable, which gives a little bit of a concern when you're reading the research and they're showing just to play devil's advocate, when they're showing how great the results are of research, these the research population is really, it's with individuals who are not suicidal and who have agreed to be in DBT for a year. So that might, you know, disproportionately show good results. So just think of that when you guys are reading research. So anyway, there's pre-treatment. This is when you're getting the client to agree to the terms of DBT. You're talking about getting, you know, taking suicide off the table. You're using certain strategies. Again, if we have a time to do another series or another lecture, I can go over all those validation strategies. But you haven't even really begun the true treatment. In stage 1, this is they've agreed to do DBT, they're invested. Your focus is going to be on emotional and behavioral discontrol. So during this time, you're going to be focusing on distress tolerance. You're going to be focusing on providing those skills, doing emotion dysregulation, talking about mindfulness, right? You're really implementing skills, providing a lot of psychoeducation. There is therapeutic work going on, but we're not talking about, you know, their early experiences with mom or their childhood abandonment issues, right? We're very skills focused. It's very time focused. Once the client has gained, I'll say, emotional stability, and they're really living a more productive life and they're not in constant crisis, then we move to stage 2. This is called quiet desperation. And the clients at this point no longer need to continue to do those skills groups. So this is more where maybe some attachment therapy will come into play. We can do some trauma-focused CBT and work on more of those long-lasting disruptions in the client's life. Stage 3, we're looking at basic problems in living. How can the client, you know, become happier? And then stage 4, we're looking more for like spiritual guidance and more of those who am I type of questions. But again, during pre-treatment and stage 1, it's that really solid DBT format of the skills every week, the individual therapy, the phone coaching. Okay. And if we go to the next slide. Oh, this is just some quotes from the DBT Adolescent Manual. We can go to the next one. I did want to talk about the diary card. Diary card, you guys don't know. All clients really, really struggle to do this. It is not fun. And I gave you, there's some handouts that I gave everyone. There's a sample diary card, there's a blank one, and there's a copy of what one looks like completed. Anyway, before you have an individual session, you ask that the client fills out a diary card. And the diary card really guides your session. It talks about if they have engaged in any type of self-harming, if they've engaged in their, we call them target behaviors, right? So have they had a relapse? Have they engaged in self-harm? Have they had unprotected sex, right? And it's going to talk about what their triggers were, what their urge level was, and if they used a skill. So this really guides the session, and your session's going to be focused on how can we prevent this from happening again. Okay. And then another thing that the main question it addresses is by the end of the session, what's coming up? How can we prepare you for this week coming up? Okay, you've got grandparents coming over and they don't know that you're gender non-binary and they call you by your birth name, not your preferred name. Well, that's going to be pretty triggering. How are we going to help you from not relapsing while grandma's over, right? And then we can come up with some skills and a safety plan for them. If we could go to the next slide. And I know I'm going through these so quickly, you guys, and I do apologize. And again, if I was there, we would actually do these things. But anyway, you may have heard of a chain analysis, right? There's also a sample chain analysis in your DBT handouts that I provided. When a client has engaged in any type of target behavior, you're going to do a chain analysis with them. And what that's going to do is it's really going to break down, why did this behavior happen, right? Why did the client feel a need to engage in self-harm? And what I really like to highlight in the chain analysis is what vulnerabilities did the client come into that day with? Did they get enough sleep the night prior? Did they get into a fight with mom? Did they do poorly on a test? Did they take their medications? Did they eat their breakfast, right? And if we see, oh shoot, you got into a fight with your boyfriend, you stayed up until 3 a.m. on social media, and you're really anxious about making the volleyball team, well, geez, you started your day with some vulnerabilities already. It makes sense, you know, that you engaged in self-harm. Well, let's talk about it. What happened right before the self-harm, you know, event? Oftentimes clients will say, I don't know. I just saw red and I just did it, right? So it's up to us to really break that down. And the idea of the chain analysis is we're chaining the events that led up to the target behavior. And what we want to do is we want to break those chains and we want to implement a skill, right? So our goal is to teach the client the skills to implement so they don't engage in their target behaviors. And if we go to the next slide, okay, we're getting there, guys. We might make it. I wanted to just go over the DBT skills that you would be teaching your clients. We've talked a little bit about mindfulness, right? Oh, and just before I get into each of these, when you are in the DBT skills group, it is not a therapeutic group, okay? This is not a process group. This is a purely psychoeducational group, and your role is really more of a teacher. And in these groups for DBT, we ask that the therapist be transparent. We ask that they share stories of a time that they've used a DBT skill and it's worked. Of course, we don't want you disclosing your deepest, darkest secrets or some really intense trauma histories, right? But you could talk about, hey, one time I got into a fight with my brother and I just wanted to wring his neck, so I had to use the distress tolerance skill. You know, I had to use my stop skill, and here's how it helped me. That way the clients can relate to you on a personal level. There's a human component to it. DBT skill groups can be fun, right? They can be jovial, lighthearted. This isn't supposed to be torturous, right? We're not asking clients to go back to school, but it is a structured group. If clients start to want to process, we ask them not to, and we ask them to bring it back to the skill they're learning. We also ask that in groups, clients do not make mention of what their target behaviors are. So if they're engaging in self-harm, they're not going to be talking about self-harm. They could say, I'm struggling with my target behavior. So we do provide them with that education too. Anyway, we're going to teach them mindfulness skills, right? This is without mindfulness, we're not able to move on to the next skill, right? This skill is present in the rest. This is being mindful in the present moment, right? You need to be present to be able to solve your problems. We also are going to teach them interpersonal effectiveness. This essentially is how to get what you want and how to say no and how to maintain appropriate relationships, right? I'm sure you guys have all heard of the dear man skill, right? Learning to self-advocate, learning how to say no to saying yes to too many things, saying no to sending nudes to a boy you just met. I can't tell you how many times I've had to teach that to clients these days. Then we also have emotion regulation. We're going to teach clients about emotions and why they have emotions. It's a survival skill, right? We're going to teach them how to balance emotions, understand them, and really how to reduce their emotional vulnerability and how to decrease their suffering. And distress tolerance. This is really a great skill for anybody to use, therapists and clients alike. This is how to get through things we can't change, right? This is how to get through a tough situation without making it worse. This is actually one of the skills that is not making anything better. We're really just sort of, with the distress tolerance, you're grinning and bearing it and not making your life more unsettling or creating more suffering for yourself. And then walking the middle path, this is the fifth skill that's added to the DBT for adolescents. This is that parenting support I was talking to you about. It's really teaching parents and their children the dialectics. Mom can be right and child can be right, right? It's creating boundaries, and it's talking about compromise and communication skills. So this is actually a skill that you would do with both the client and the child. I'm sorry, the client and their parents. And when we do a true DBT program for adolescents, it's very interesting because when the clients are in group getting their DBT skills, the parents are also getting the same skill set. So they're working on their own skills at the same time, and then they can come together and discuss how to utilize these together. And then if we go to the next slide, And I know we have like 3 minutes, which is perfect because I'll just finish the slide and answer any questions anyone might have. The last thing, just some validation skills for us. You want to stay awake, literally, right? Literally stay awake, but really be mindful of what the client's saying, right? I think we've all been there. In session, you're thinking about, oh my gosh, I have to do all this laundry. I got my daughter's bake sale that I have to get ready for. What do I need to get from the grocery store? Did I pay that bill? Did I turn off my hair straightener today? Right? And then we aren't paying attention to what our client just said. So we really need to be in the moment with them. Providing accurate reflection, right? Summarizing the session. What I'm hearing you saying is X, Y, and Z. And these all sound like really basic clinical skills, but sometimes when we've been in practice for so long, we forget the core skills that we were taught at the beginning, right? So DBT is very simplistic, bringing us back to our basics. And sometimes that's really what clients need. We also want to provide radical genuineness, right? Especially working with adolescents. If you are not genuinely being yourself, they will sniff that out in a second, right? If you're dorky and goofy in real life, be dorky and goofy in session. Share some personal things. I think that's when I teach DBT, that's the hardest thing for people to get over because we've been taught to create boundaries. And of course, I'm not telling you all to not be professional, but we do need to provide that human connection. We do need to share little bits of ourselves in order for clients to feel safe and to know that these are skills that they can use. So being a little bit genuine does help with that. We also, of course, we want to create a validating environment for them because up to this point, they have been invalidated by everyone, friends, family, teachers, you know, you name it. So we really want to create that safe space for them. Whew, that was a lot of information. And I appreciate you all sitting through it all. And I'm happy to take any questions if anyone has any.
We'll give people some time to either raise their hand so that you can be unmuted or to type your questions. The questions that have been coming in have been great. And Dr. Roye, you've been doing a great job multitasking the questions coming in while giving your presentation. So anything additional or anything to expand upon that anybody would like to hear about?
Hi, Dr. Rowe. We have one person who raised their hand, David. Oh,
Yeah.
It went away. Just kidding. Let me allow him to.
Okay, I don't know how to allow David to ask.
Yeah, I can control it from my end. No worries. And then we do have 2 questions under the Q&A window as well.
I see that. So the information that's shared, is it strictly for an inpatient, outpatient program or also applicable for private practice? I think it's applicable in any setting. I do work in a residential and IOP PHP, and we're not a DBT program, but we do have a 4-week skills training program that we have our clients go through. You can absolutely incorporate some of the DBT skills with your clients in session. I think it's a great idea to utilize a diary card and a chain analysis to help. The only caveat I will say is that if you're not a true DBT provider or a true DBT program, to just educate your clients on what that means and educate them on some of the limitations that you have, like the phone coaching, just so that we're not perpetuating misinformation about DBT. But you can absolutely, clients can get just as much success with just the skills component as they would a DBT program with the individual DBT therapy and the skills therapy.
And then I have unmuted David as well.
Okay, great.
Oh, and he also typed in his question in the Q&A window.
Oh, can I talk about how to address long-term chronic depression in a teen that does not vary with life events? Meaning how would DBT help a teen with chronic depression? Am I understanding that correctly, David?
Yes, yes, you are.
Okay. So the skills could help in terms of emotion regulation. That could be a really good thing to introduce to them.
Maybe I should give a little bit of background. So
Yeah.
in our clinic, we have a lot of kids who have chronic, what used to be called dysthymia. They may have major depressive episodes, but they're pretty much depressed most of the time, irritable most of the time, and it may not particularly vary with who's provoking them or not. What do you do in those cases, given that DBT is very oriented around reactivity?
Yes, so that's a great question. So DBT is really good for individuals that would be considered more in a crisis mode. So you're providing skills to keep them out of crisis, to prevent crises. If these individuals are dysthymic and this is just sort of their baseline and they are okay with that, I don't know necessarily that DBT would be the most beneficial. You could of course help them if they were engaging in self-harm and suicidal thinking. Distress tolerance skills would be beneficial. I think emotion regulation skills would be beneficial, but if they're not in that chaotic crisis mode, then DBT may not be the best.
Okay, thank you.
Yeah, of course. And certainly, mindfulness skills can help them. And if they are, struggling with self-esteem and not, wanting to advocate for themselves, maybe some interpersonal effectiveness. But again, yeah, DBT targets the more crises situations. Great question.
Hi, Dr. Rowe. We have 2 questions additionally posted in the chat window. And then one more just came in the question and answer window.
Yes. Okay. So what to look out for when reviewing literature on DBT? Yes. So when we are looking at the DBT literature, you just want to see who the sample was. Because if they're using, like Linehan's research is done, not to say it's done poorly or incorrectly, but the individuals who are in her research group have agreed to DBT. And if you remember, part of the agreements to engage in DBT, you're making a year-long commitment and you're agreeing to take suicidal behaviors off the table. So by nature, these individuals have already determined that they want the help, that they're going to engage in treatment, and that they're going to reach out to their therapist before engaging in any type of suicidal behavior. So that's a person who is in less crisis than maybe some of the people that we're treating. I don't know who everyone treats, but UCLA, probably some of you work in the hospital inpatient setting. I'm sure some of you work in residential settings. Our clients are not agreeing to be in therapy for a year. They're not agreeing to be non-suicidal. They're actively engaging in self-harm. So if we were to do some true DBT experiments with that group of people, the results I would predict, be a little bit different than the original sample that Linehan used. So I hope that answered that question about the research. Do the skills need to be taught in the order they were presented? So that's a great question. The skills need to be taught in a certain order. So the first thing you teach is orientation, and that you're orienting the clients to what DBT is, what DBT isn't, and what they can expect to get out of the skills. What they can expect is they can get, skills on those 4 groups that we talked about: mindfulness, emotion regulations. And we need to really educate people that these skills work some of the time for some people. And if one skill doesn't work, then you need to move to the next skill to see if that will work. So we want to be really transparent in this type of treatment, right? We're not promising the world. This isn't a magic cure-all. This isn't a pill that's going to take away symptoms. It's going to take a lot of work. And one skill might not work, so you need to keep trying. So that's what comes with the orientation, right? Clients can really understand the core concepts. You're going to be teaching what a dialectic is, what a diary card is. The next skill you need to teach is mindfulness. That is the very first skill always that needs to be taught, because like I said, if we're unable to be mindful, we're unable to engage in any other skill. After mindfulness is taught, you need to go back to orientation, because it takes a few times to learn these concepts. They're a little bit abstract for some people. So, and we're really working on generalizing the information, right, and reinforcing information. The more we repeat it, the more different ways we can teach it, the better. So after that, then you can teach any of the other skills, depending on what symptomology the clients are coming in with. If this is a client who is suicidal, I would teach them distress tolerance next. I don't know that they necessarily need to talk about interpersonal effectiveness before learning to tolerate distress. So you can rearrange that, but again, it needs to be orientation, mindfulness, orientation again. Then you can pick another skill set. After every new skill set is introduced, the following week should be orientation again, because you can never teach clients enough about the core principles of DBT. I hope that made sense. If anyone has questions and wants me to explain that further, let me know.
And then, hi, Dr. Rowe. We have two more questions that were asked earlier. One is from Julia. She asked, are there any DBT materials or handouts that are available in other languages?
Oh, that is a great, I think that the skills manual is available in Spanish. I'm not 100% certain, but I think it is. If it's not, I would just be mindful, you cannot just take a skill worksheet and translate it on your own. It needs to be validated in the Spanish speaking population to make sure it's accurately translating the concepts. So that's my only caveat on that. I got another question asking about where to purchase the skills manual. You can get it on Amazon.
And then the last question is from Sierra. She asked, do the skills need to be taught in the order they were presented: core mindfulness, interpersonal effectiveness, emotion regulation, distress tolerance, walking in the middle path?
Yeah, I think I answered that one. So you would need to do orientation first, then mindfulness, orientation again, then you can do any of the other skills, but after any new skill is introduced, you want to do orientation again.
Sorry, I read the wrong question. It was Andy. This is the last question. Andy asked, what's the youngest age you would recommend using the chain analysis with?
I work with adolescents, so I personally have not used it with anyone under 12 years old. I would also argue that developmentally, it might be really challenging for anyone who is younger than 12 to be able to analyze what happened before, what were my vulnerabilities, maybe a modified one, but with 12 and up, I've seen success.
Great. Thank you so much. Thank you for a wonderful presentation, and thank you all for attending our STAR seminar. Take good care, everyone.
Thanks so much. Bye.